Hello all. So in the last video, we were discussed about the definition of the growth, then the what are the factors which influence the growth, then parameters which are used to describe the growth like height, weight, arm span, head circumference, like that. Then we also discussed about the growth curves, that is different rates of growth of different tissues in our body. Then also we discussed about the growth charts, importance of the use of the growth charts. Then there are some basic idea of the growth charts is that it consists of x-axis which is usually age in years or months, and y-axis which can be weight in kilogram, height in centimeter or the inches, head circumference, then weight for height, BMI in kilogram per meter. These are all plotted in the y-axis. And the growth charts which can be divided into the y-axis which can be divided into different divisions uh, in the percentage charts. That is, first chart is third centile, then 50th, then 15th, 50th, 85th, and 97th percentage chart. And on this set score or the standard deviation chart, there will be 0 on the center, and then above that +1, +2, +3, and below that is -1, -2, -3. According to that, we can plot. And the normal, if the graph, if we plotted a graph which is between this normal range, and it is normal, but it is above or below that normal range, it is called as abnormal deviation from the normal growth pattern. So it should be kept in mind. Then, how often we will monitor the growth in a child? That is during the vaccination visits, like that is at the birth, 6, 10, 14 weeks, and 6, 9, and 15 months of age. We have to assess the length, weight, and head circumference. And 18 months to 3 years of age, we have to assess the length or height, weight, and head circumference 6 monthly. And during the 3 to 5 years of age, we have to assess the height and weight 6 monthly. And during the 6 to 8 years of age, 6 monthly, we have to assess the height, weight, and BMI yearly. And 9 to 18 years of age, yearly, we have to assess height, weight, BMI, and sexual maturity rating. So these are the frequency of the growth monitoring in the child. Then uh, uh, how will you interpret all these data from the growth chart? That is, how will you interpret whether the child is underweight or the stunting or the under or severe stunting, like that? It is using in the OPK there will be a chart. നമുക്ക് പോയി നമുക്കൊന്ന് നോക്കിയാൽ മതി, അപ്പോൾ മനസ്സിലാവും. എങ്ങനെ മനസ്സിലാവുന്നത് വെച്ചാൽ, by when we are plotting a graph, that is weight for age graph, and if the weight for height graph, the graph is between the -2 standard deviation or the less than third centile, it is called the underweight. And if it is -3 standard deviation, it is called the severely underweight. And if we plotted a graph by plotting height and age, if we get a graph, it is less than -2 standard deviation or the less than third centile, it is called the stunting or the short stature. If it is less than -3 standard deviation, it is called the severe stunting. And likewise, if we plotted a graph of for weight for height, if it is below -2 standard deviation or less than third centile, it is called is wasting. And if it is less than -3 standard deviation, it is called the severe wasting. Okay, so likewise, we can interpret the data using the growth chart. Then the next important three topics we are going to discuss are, first one is the failure to thrive. That is most often asked in our university exam as short notes or the short essays. And the next topics are the microcephaly and macrocephaly. The microcephaly and microcephaly is usually asked as a short note, and in from the macrocephaly there will be 1 mark or likewise questions are there. So from the failure to thrive, if it is asked as a short essay or short note, we have to ask according to the headings. So first of all, we have to write a head definition. Then we have to write about the etiology, then the clinical features, then diagnosis, and then treatment and the prognosis. So in the definition heading, we have to write that failure to thrive is used to describe infants and children up to 5 years of age. That is, beyond that, we did not use the term failure to thrive. It is usually used to describe the infants and children up to 5 years of age. Okay, so it is usually defined as physical growth which is less than other children of same age and sex. അതായത് യൂഷ്വലി ഇപ്പം ഒരു കുട്ടിയുടെ അതേ ഏജിലുള്ള ചിൽഡ്രനെ കാണും അറ്റൈൻ ചെയ്യുന്ന ഗ്രോത്ത്, അതായത് ഫിസിക്കൽ ഗ്രോത്ത് കുറവാണെങ്കിൽ അതിനെ പറയുന്ന പേരാണ് ഫെയിൽഡ് ത്രൈവ്. That is inadequate weight gain over a time compared to the children of the same age and sex. It usually describe the children less than 5 years of age whose weight is below third percentile or fail to gain overweight over a period of time, or a crossing over of 2 percentile lines downward on a growth chart. That is called as the failure to thrive. That is the definition of the failure to thrive. Then etiology. During the etiology, when we come to the etiology, we have two important etiological factors, that is non-organic factors and the organic factor, which are the etiology for the failure to thrive. In the non-organic failure to thrive, it is the most important, the most common cause for the failure to thrive. That's 80% contributed by this non-organic failure to thrive. So this is it is also known as the psychosocial factors, that is both social factors and also the psychological factors which influence the growth in a child. That is the poverty, the factors are the poverty, misconception of the feeding, inadequate breastfeeding and feeding diluted formulae, inadequate complementary feeding, emotional deprivation, child abuse and child neglect. These are the non-organic or the psychosocial factors which contribute to the failure to thrive. Then, the organic failure to thrive is the 20% is contributed by the organic causes. That is, there will be an underlying disease is there. That is system wise, this is classified here. That is, because of this underlying organic disorder, the child have the failure to thrive. So the system wise, നമുക്ക് memorize ചെയ്യാൻ, നമുക്ക് remember ചെയ്യാൻ ഏറ്റവും important ആയിട്ട് system wise ഓർത്തിരിക്കുന്നതായിരിക്കും. First is the gastrointestinal system, recurrent disorders like recurrent diarrhea, malabsorption, inflammatory bowel disease, pyloric stenosis. And in the respiratory system, we have asthma, cystic fibrosis, bronchopulmonary dysplasia. And in the cardiovascular system, congenital heart disease and the congestive cardiac failure. And the renal, we have if the child is having the urinary tract infections, renal failure, and renal tubular acidosis. And in the endocrine, hypothyroidism, diabetes mellitus, adrenal insufficiency, and growth hormone deficiency. And the CNS disorders, if the child is having the cerebral palsy and the CNS anomalies, the genetic disorders, Down syndrome, and inborn errors of the metabolism, infections, if the child is having the tuberculosis, HIV, and worm infestation, and the miscellaneous disease like immunodeficiency disorders in the child, collagen vascular disorders, and malignancy. These are the system-wise classification of the organic cause for the organic disorders for the organic causes for the failure to thrive in the child that contribute only up to 20%. Then the next heading is our or clinical features. That is, if the child is presented with a poor growth associated with the poor cognition and poor development, we have to consider it as failure to thrive. We have to consider in the child as the failure to thrive, and we have to further investigate the child. That is, by if a child is presenting with the failure to thrive or poor growth, we have to investigate by first of all, we have to take history, thorough history regarding the nutritional history, dietary, that is dietary history, then any uh, disease history in the past, and if there is any present symptoms is present. Likewise, we have to take history, then we have a physical examination, we have to do a physical examination, and then also observation of family interactions are important to look for any psychosocial factors. So if there is any suspected cases of organic fertility which is obtained from our history physical examination, we have to further investigate. So the first line investigations to rule out these are the complete blood count and with the ESR, and urine and stool microscopy and culture, renal and liver function test, also serum electrolytes. And if our child is having the failure to thrive, it can be due to the inadequate provision of the calorie, that as in the psychosocial factors. So if we give the adequate food or the nutrition to this child, if the child improves, it is a good indicator for the child is having the failed thrive because of this inadequate nutritional provision. So that also kept in mind while doing the investigation. So the next our heading is the treatment or the management part. That is the most often it is 80% of the failure to thrive is caused due to the psychosocial factors, or that is due to the inadequate calories provision, or due to any emotional or psychological factors. So we have to, for the adequate supplementation of nutrients, we have to go for nutritional rehabilitation, establishment of the breastfeeding and adequate complementary feeding, then nasogastric tube feeding in the initial phases in the severe failure to thrive, which may be required. Adequate calories and protein should be provided, and in treatment of the underlying organic condition. That is, if the failure to thrive is due to underlying organic condition, we have to treat accordingly that condition, and that results in improvement in the child. Then we have to manage the psychosocial issues by counseling and resolution of the family issues. So these are the treatment options. So then prognosis, if there is early and adequate treatment is given for this failed to thrive child, there will be a better prognosis there. So this is all about the um, our discussion on the failed to thrive. Next, we have the discussion on the microcephaly. In the microcephaly, it is defined as uh, the head circumference that is less than -3 standard deviation of the mean. Okay. So the microcephaly is defined as the that is altered head circumference. That is, head size is less than normal. It is called as the microcephaly. That is, head circumference -3 standard deviation of the mean. Okay, so and its causes can be ഇത് essays, ലോങ് എസ്സേസ് ഷോർട്ട് എസ്സേസ് ആയിട്ടില്ലെങ്കിൽ ഒരു ഷോർട്ട് നോട്ട് ആയിട്ട് നമ്മളോട് ചോദിക്കാൻ പറ്റുന്ന ക്വസ്റ്റ്യൻ ആണ്. അപ്പം ക്യാൻ ഡിഫറെൻറ്റ് കോസസ് ഫോർ ദി മൈക്രോസെഫാലിസ് ദ ഫസ്റ്റ് വൺ primary causes, secondary causes, and late onset secondary acquired microcephaly. There are three important major headings are there for the causes of the um, microcephaly. Okay. In the microcephaly, the first cause is the uh, primary cause. That is, no underlying diseases that is due to primary causes. Like we can easily remember by using a mnemonic. That is why Dr. Russell Peter can't see ejection fraction in child. That is the mnemonic. This is the why Dr. Russell Peter can't see ejection fraction in a child. So W, which means Williams syndrome, and D means Down syndrome. That is, each word's first letter we can use to remember this primary cause for the microcephaly. W is the Williams syndrome, D is the Down syndrome, R is the Russell, R is the Robinson-Tabby syndrome, and the Peter P is the Petau syndrome, and the can't see is the Kreidu-Church syndrome, and C is the S is the Smith syndrome, and ejection is the E is the Edwards syndrome, and fraction is the familial causes for the microcephaly, and the C is the Cornelia de Lange syndrome. Okay, so this is the mnemonic for the remembering the primary causes for the microcephaly, and then we have the secondary causes like congenital infections with the cytomegalovirus, rubella, toxoplasmosis, then maternal alcohol or the smoking, maternal phenylketonuria, infections with meningitis or the encephalitis, asphyxia, protein allergy, malnutrition, then uncorrected hypoglycemia. These are the secondary causes. So then third is the late onset secondary acquired microcephaly. That is due to the Rett syndrome, Angelman syndrome, and Seckel syndrome. So these are the three major heading for the causes for the microcephaly. First is the primary. To remember that there is a mnemonic by Dr. Russell Peter Kahn's ejection fraction child, and secondary cause like congenital infections, maternal alcohol smoking, maternal PKU, infections, asphyxia, protein energy malnutrition, uncorrected hypoglycemia. And late onset is due to Rett syndrome, Angelman syndrome, and Seckel syndrome. Then, so this is all about the microcephaly. And there is no specific treatment for the microcephaly. Then the next is the macrocephaly. The macrocephaly it is the ulta of the microcephaly. That is, microcephaly is the decrease in the head size, but macrocephaly is the increase in the head size compared to the normal. Okay, so it is usually due to നമുക്ക് റിമെമ്പർ ഓർക്കാൻ വേണ്ടിയിട്ട് എങ്ങനെയൊക്കെയാണ് നമ്മുടെ ഹെഡ് സൈസ് വളരാൻ കാരണം. ഒന്ന് വെച്ചാൽ നമ്മുടെ ഹെഡിൻ്റെ ഉള്ളിലുള്ള എന്താണോ അത് വലുതാവണം, അതായത് മെഗാനോസെഫാലി ആവണം. ദാറ്റ് ഈസ് ദ ബ്രെയിൻ ടിഷ്യൂ, ദ പാരൻകൈമ is enlarged. That is mechalencephaly. Then, if there is any fluid collection, that also contributes to increase the head size. That is hydrocephalus-like conditions. Then, if there is any thick cranium, that also increases the head size. Then, also if there is any hemorrhage like extra dural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, that also results in the increase in the head size. Then we have the hypervitaminosis A, lead poisoning, intracranial mass, also the abscess, cyst, tumor, which also results in the increase in the size of the head. And also if there is any galactosemia, which also results in the increase in the head size. So these are the 8 important factors which are the causes for the microcephaly. Okay, mechalencephaly is the brain of the parenchyma is increased. That will also results in the increase in the head size. Hydrocephalus increase the fluid collection, also results in the increased head size. The cranium hemorrhage, intracranial hemorrhage like extradural hemorrhage, subdural hemorrhage, and subarachnoid hemorrhage. Hypervitaminosis, say lead poisoning, intracranial mass cyst, abscess, galactosemia, which are the important causes for the microcephaly. So these are the important three topics, today's three topics. So thank you all.